Good morning. My name is Meyer. I am a pilot project manager consultant to the California Emergency Medical Services Authority and currently managing and consulting in reference to community paramedicine pilot projects throughout the state of California. So the objectives of my talk with you today is deal with the working definition of a community paramedic program, the rationale behind the use of the community paramedicine programs, the different community paramedicine program concepts that are used throughout California in the pilot project, and then an overview of the Office of State Health Planning Development community paramedicine pilot project and findings. So the working definition of community paramedic in the state of California is really, and across the United States, is a locally determined community-based collaborative model. Really, we take the skills of the paramedic and EMS system and leverage those to deal with access to care that's identified through a community-specific healthcare needs assessment. So in order for a program to be approved, would have to be a community health care needs assessment so that the different concepts that are authorized under our current law can be applied appropriately. There's new types of community-based healthcare services that bridge primary care and emergency care, and we utilize paramedics outside their traditional emergency response and transport roles. In the state of California, a paramedic without the additional training as a community paramedic is only able to treat a patient at the scene of an emergency or during transport to an acute care hospital, or until such time as the patient is turned over to a higher medical authority at the hospital. So why paramedics? We believe paramedics are really positioned appropriately. They're always available 24 hours a day, 7 days a week. They're geographically diverse in nearly all communities, inner city and rural. Very important that community paramedicine programs cover the rural area where there is a less opportunity for emergency clinics and so forth. Obviously, they're mobile and can respond during all hours of the day and night. Paramedics are trusted and accepted by the public, and they're trained to make health assessment outside of the hospital. And most importantly, they operate under the medical control as part of an organized systems approach to patient care. So when we look over to the community paramedic, paramedicine, community paramedicine, so it's really a locally designed community-based collaborative model. So a community paramedic program in one area, the way it's implemented may be implemented different than it would be in maybe their neighboring county. So community paramedic, with the additional standardized training, and our community paramedics receive approximately 150 hours of additional community education in order for them to be able to work within that capacity. And again, it's under local medical control and has to be part of a community-based team of health and social service providers. So the concepts that we looked at in the state of California, and again, these are most of these are used across the United States when community paramedicine programs are implemented, is what we call the post-discharge, post-hospital discharge short-term follow-up. And in this particular concept, we focused on congestive heart failure discharge from patients to home, because we were seeing, and I'll cover this a little later, we were seeing a large number of readmissions within the first 72 hours of the patient getting to their home. We also looked at frequent EMS user case management, and what we're looking at here is patients that are calling 911 several times a month. And 911 is our emergency number. I'm not too sure what yours in Vienna might be, but I'm sure you have one. And then one that's not really used across the United States, but it was a community need, and that's to directly observe therapy for tuberculosis, coupled with the public health department in a collaborative effect. And this is where a patient who is diagnosed with tuberculosis is required by law to take certain medications, and it has to be directly observed by a public health official, or in this case, the community paramedic has to observe them actually taking the medicine. And that was normally face-to-face. However, with COVID, it was done virtually in most cases. However, a lot of our tuberculosis patients are homeless and obviously don't have the ability to use virtual communication. So we did have community paramedics with the proper, protective equipment go out and deal with this. We also had hospice support, and we'll get a little deeper into the details, but in this particular situation, hospice support is a collaboration with the hospice healthcare nurses, and a lot of the families, while they have accepted hospice as a really an end of life scenario, transition as we call it, sometimes when the end is close, they call the family calls the other family members together, and those family members who have not been dealing with the hospice patient at their home wants to call 911 and have the patient taken to the hospital, which is totally opposite of the desires of the patient. And so what we do here is we have a community paramedicine liaison with the hospice nurse before the hospice nurse's arrival to help support the family until an appropriate hospice nurse can arrive and to assist. We also deal with alternate destination we started with three particular areas: alternate destination to mental health crisis centers, alternate destination to sobering centers for our inebriates, and an alternate destination to urgent care centers. And the urgent care center program under the pilot was suspended because we weren't gathering enough detail, and it was not widely accepted by the urgent care center rank and file. So, as I mentioned, these were community paramedicine pilot projects, still are, because we're pending regulations. We have 14 projects. There are 10 sites, and they're spread throughout mostly the Central California, Southern California, with some up in the northern rural areas. And each one had selected a concept or two concepts to test within their community. So not all of these are doing all of these concepts. They're doing one or two because it was really a test under the pilot project. So one of the questions keeps being asked is, what is your interface in case management with social workers? Well, with our frequent 911 user community paramedics, they are accompanied by a mental health social worker. So you have mental health social workers in the field to help assess those patients. And then what the paramedic, the community paramedic does additionally is they case management with these frequent 911 users and interact with all of the appropriate referral sources and set up, doctor's appointments, making sure that they're getting their medications on time, and so on and so forth. So it's really a case management scenario. So our pilot projects in California under the law required an independent evaluator to look at the program that we were actually working with and evaluated for, the efficacy and efficiency of the program, and then also goes into some cost saving. So the independent evaluator for this particular project is the University of California, San Francisco, a well-known organization within California, and the independent evaluator, Dr. Janet Kaufman, is known from across the United States as being one of the top evaluators for these types of programs. So we'll show you some data here. We've got the concept set here. I think what jumps off this page, as you will see, is that the majority of the enrollees into the program are in fact the mental health patients. And we're dealing with a very high homeless population throughout California. A lot of these homeless patients do have behavioral health issues. And so, as you can see, the numbers are quite high. The second highest is the sobering center, and dealing with the inebriants. Sobering center programs are implemented in Los Angeles, a very large county within California, and the city of San Francisco, another large metropolitan area. Both of those areas have significant homeless populations, and these were the patients that were actually, prior to the pilot project, were all being taken to emergency rooms, and as we say, clogging up the emergency rooms because there just weren't enough beds to handle them all. So the average age of our patients, post-discharge, right at the Medicare age, 66 in the United States. Our frequent EMS users who are calling 911 more than 10 to 20 times a month were average age of about 65. Your tuberculosis patients, about 54 years old. Your hospice patients, appropriately at the highest average age. But what was surprising to us was the mental health patients that we were dealing with, or are dealing with. Average age is 36, so it's a fairly young population. And then you have your sobering center or your inebriate, coming in about the average age of about 50 years old. So the post-discharge follow-up was reduced readmission rates. So the 30-day readmission rates were lower than their partner hospitals' readmission rates in 4 of the 5 pilots. So what we were able to do was to reduce these readmission rates significantly by having a paramedic go and do a face-to-face within 24 to 48 hours of discharge from an acute care hospital. And the community paramedic provided additional instructions about how to take medications properly. To about 18% of the patients, they didn't understand that when they got a bag of medicine from the hospital to take home with them, and traditionally the older population, they have their medications out on their kitchen table and so forth. They were then taking the new bag of medicine, putting it with all the old medicines. And when they asked, well, how are you taking your medicines? Well, I take one out of this bottle, one out of this bottle, one out of this bottle. And they were basically overdosing on the diuretic that is used for treatment of congestive heart failure. And we use the drug Lasix or furosemide in California. And what was happening was they were not backing that up with potassium. So if you're taking high doses of Lasix, you're wiping out your diuresing, but you're also diuresing all your potassium. And what we found was that's what was putting the patients back in the hospital, where they were having cardiac situations because they had diuresed and not replaced their potassium. So this is just a quick chart. You will see, as you see here, The light blue color is the results of the pilot project, and the black is the historical readmission rates from the hospitals prior to the pilot. As you will notice, where the arrow points in what we call Butte County, their congestive heart failure patient actually, readmission rate actually went up. When we explored that, we found out that they were not doing face-to-face with the patient. They were making phone calls. And that's no different than a discharge nurse calling in and saying, you know, Mr. Meyer, how are you feeling today? Well, if I've just gotten out of the hospital, I don't want to be talking to anybody on the telephone. But to have a paramedic come, take my vital signs, sit at my kitchen table and talk to me, clearly, as you can see here, had major, major positive results. So, and that's why we do pilot studies. You know, ironically, this one particular hospital didn't do it the way we had set it up, but it actually shows what happens when you don't. So, and then we have the frequent users. Again, the clients link clients to organizations that provide a wide range of services. We did reduce the number of 911 calls made on behalf of these enrollees and the number of patients transported to emergency departments. And patients were transported to primary care clinics and other service providers that really were better equipped for taking care of their needs. And we did talk a little bit about the mental health projects, which enabled the patients with mental illnesses to seek care from a mental health professional more quickly than they would if had they been gone to an emergency department. Because when they were going to an emergency department, we used the term they sat along the wall. And they weren't actually being seen and cared for a number of hours. And then ultimately they were being transported to a crisis center. So paramedics are trained to do assessment, medical assessment clearances for these mental health patients. And these patients are also evaluated on scene by the mental health social worker that accompanies the paramedics on most of these calls. So we did see a significant decrease in that. Sobering center findings in these particular departments, mostly in San Francisco and Los Angeles. We reduced the number of enrollees being transported to the emergency department as well. And the community paramedics participating in San Francisco's program, Sobering Center Project, also partnered with the Sobering Center staff during the COVID pandemic area. Well, we still have that, but not as significantly. And they were collaborating to take these the services of the Sobering Center and creating a quarantined, isolated center for the homeless population to make sure that they would be properly cared for. The urgent care centers, as I mentioned, we did enroll about 48 patients into the urgent care center pilot project, which was substantially lower than we anticipated. Why we clearly had the support of the administration of the urgent care centers. We did not anticipate the resistance at the line staff within the urgent care centers, and a lot of the patients that we were trying to get routed to an urgent care center for their broken finger or less urgent care needs, they were being turned away, and we were actually taking them to the emergency room anyway. So we suspended that program. And the pilot project is currently not being used in the state of California today. And again, I talked about the dispensing of appropriate doses of tuberculosis medications, and then the directly observed. And then the Hospice Project, as I mentioned, we reduced the percentage of hospice patients transported to the ED from 80% down to 28%. So again, this is increasing the number of patients whose wishes were to remain at home, and we were able to honor them. And then community paramedic was not making that decision alone. They were, again, alerted the hospice nurses who would arrive on scene, but not as quickly as a community paramedic could, liaison with the family. And the community paramedic was also able to talk to and assist with unmet needs of the hospice. So when you look at it from a savings perspective, and in my 40 years in EMS, I look at things from a clinical health perspective first, and then hopefully we realize savings by doing the appropriate thing and getting the patients to the right place so we can continue to service more patients along the way. So savings were realized by the health plans, meaning the insurance services or companies, from reduction in ambulance transports to ED visits, and also with in reference to inpatient admissions. So, and when you're talking about readmissions in California under the Medicare program, hospitals are penalized if they have to readmit a patient with the same diagnosis within the first 30 days. So it's an incentive for them to make sure that they don't have to readmit the patient, but at the same time making sure that their needs are being met. So Medicare realized the largest saving because it's the age population for us was the largest enrollment. Projects also generated substantial savings for our Medi-Cal Medicaid population, which is really our welfare insurance programs. And then post-discharge projects lowered the risk of Medicare penalties, as I was just mentioning, for excess readmissions. And then the frequent EMS user projects reduced the amount of uncompensated care provided to uninsured persons. So by taking the patient directly to where they needed to be cared for, you're not having not only the burden, but the cost of the emergency room cost. Now, because in California, the cost to go to emergency room is probably 4 times, 5 times what it costs taken to directly to the appropriate care facilities. So what's the conclusion from our independent evaluators? Is that clearly specifically trained paramedics can provide service beyond their traditional and current statutory roles in California. Projects have improved patients' well-being. There were no adverse outcomes for patients. No other health professionals were displaced. When we were first looking at this program, the registered nurses in the state of California thought that the community paramedic was taking the jobs away from them. However, the registered nurses, there weren't enough of them to go out and do the job that the community paramedic was doing. And in most cases, yielded savings from health plans and hospitals. So from this pilot project, we needed to go and get legislation in California to allow the pilot project to extend throughout the state of California. So we were able to put into legislation the directly observed therapy programs, case management for frequent emergency medical services, and then the triaged alternate destination programs for both sobering centers and the mental health crisis centers. We did not have urgent care included in this particular piece of legislation. And I'm sure in Vienna you don't have politics, but from a political point of view, we were unable to get the post-discharge concept within this current piece of legislation because of the large nurse lobby that we have here in the state of California. So as I put here, as I just commented, our post-discharge follow-up programs are not allowed to continue after 2024. when this particular piece of legislation sunsets, but it is our hope that we are able to, in the enabling and extension of the legislation, be able to include urgent care, not urgent care, post-discharge back into our overall community medicine concept. So that is what I have to offer you today, and I understand that there will be ability for questions to be emailed to me, and I will be more than willing to respond to those as I receive them. And it's been my pleasure to take time and spend with you this morning.